Now I'll start sharing my slides.
Yeah, okay. Yeah, Shishir, I can hear you. I've stopped sharing, so I suppose you can do it now.
Can you see my slides?
Yeah. No.
Is it now visible?
Yes, sir, it's visible. It's visible to us.
I can't see.
Okay.
I can't.
Shall I start?
Yeah, I can see it now. Shishir, you can start, but ideally I should have introduced you to this group, but I suppose it is superfluous and waste of time to try and introduce you. All I would say, one line is that Shishir was such a fantastic addition to the department that I believe without him, the department wouldn't have progressed to what it is today. Shishir, go ahead.
Thank you, sir, for the kind words. What I plan to do today is to talk something about the ABO incompatible kidney transplant and what is it and what is our experience about it. Very briefly, I will discuss about the biology of the ABO group system, the evolution of ABO incompatible transplant, the current protocols, and what has been our experience. David Hume in 1955, he's one of the pioneers in kidney transplantation, said that we do not feel that a renal transplant is the presence of blood group incompatibility is wise. And I think for a long period of time, because it was known and it was believed that as soon as you put a kidney which is ABO incompatible, it would reject on table, it was not attempted. However, in 1982, a major breakthrough happened when Alexander from Belgium actually did an ABO incompatible transplant. They desensitized the patient using plasmapheresis, splenectomy, putting blood group antigens so as to remove the antibodies, used ATG, prednisone, azathioprine in various combinations, and then later on cyclosporine. The important point I want to show you is that those grafts, which there were 31 transplants done at that time, and if you see a couple of years, almost 15 years down the line, a majority of them are still working. So there were initial losses, but those who did well continue to do well. And that is how the journey of ABO incompatible transplant began. Later on, the Japanese group actually did a major contribution to the ABO incompatible transplant, because in Japan, the cadaver transplant is very limited because of cultural reasons, and therefore ABO incompatible has to rely upon, because families are also small over there. What is the problem of ABO incompatible transplant? As we all know that we have natural antibodies to the blood groups that we do not have. So a blood group O patient will have anti-A and anti-B antibodies. A group will have anti-B antibodies. B group will have anti-A antibodies. And AB group will have no natural antibodies in them. So secretors express more antigen in the kidney. So these antigens which are on the RBCs are also expressed in the kidneys, and therefore you can get rejection because of that. Antibodies are usually IgM, IgA, and just okay. Hello, am I audible? Because
yes, you are audible. Go ahead.
So in transplantation, the IgG is important, and the role of IgM is not clear. So why is there, are the antigens which are seen in the blood, that is RBCs, are similar to those we have seen on the kidney? Probably not. There are some differences between the ABO histo blood group antigens which are present on the kidney compared to that which are present on the RBCs. And therefore you find that initially there are antibodies to it, but once there is some degree of these are a little different from the normal antigen found in the RBCs, and therefore they don't behave in the same way. They behave a little different way compared to those in the RBCs. Not fully understood, but probably that is the reason that once the kidney starts doing well, usually that is not a problem in the long-term graft acceptance. Another important point is about which are the type of the antigens which are expressed on the endothelia. A1 blood group, they are very well expressed on the endothelia compared to the A2 blood group. A2 blood group antigens are very minimally expressed on the endothelia of the kidney. And therefore, A2 can be taken as an O, like an O group, and therefore A2 can be transplanted to O group patients also without any difficulty. What is the usual natural history of an ABO incompatible transplant? When you do an ABO incompatible transplant, initial first 2 weeks generally go as it happens in normal transplant. However, if desensitization has not been done, care has not been taken, usually after the first 7 days, you start getting antibodies which can form against the endothelia, and then you can get a really critical period. But if you pass the first 12 weeks, then usually there is a stable period and no problem happens, and they are like any other transplant. So it is very important that a critical period between 1 week to 8 weeks are monitored very closely to see if any evidence of rejection is there or not, and to see whether your desensitization has been adequately done or not. So what is the mechanism of rejection acceptance of ABO incompatible graft? In the absence of desensitization, free from anti-A and anti-B antibodies will lead to severe ABMR. Desensitization for a limited period produces accommodation to the graft despite reappearance of the antibodies. And therefore, once you do desensitization, though the antibodies come up again, they are usually not harmful to the graft. So as you can see here, that what is happening in the ABO incompatible transplant, this is acute antibody-mediated rejection where you get peritubular C4D staining. This is a cellular rejection. In transplant, what happens is, though you get a peritubular C4D staining and telling you that there is some activation of the IgG antibodies, but there is no rejection. And this is what is called as accommodation. Though the antibodies are present, though there are signatures of the antibodies present on the peritubular capillaries, but there is no rejection. And this is possibly explained that these grafts get accommodated to it, and no problem happens in the long term. Now, the important thing about an ABO incompatible transplant is all thing in the preparation. That is, everything prior to the transplant. The better you prepare the patient, the less risk of getting any problems in the post-operative period. And the key thing that begins with the preparation is measuring the antibody. And there are many techniques of measuring the antibody: the tube technique, the gel technique, and the flow cytometry. We use the gel technique because it provides us consistent results. And to be very lucky that we have a very good pathology department, and Dr. Amit and Dr. Sailesh have been doing this test with significant accuracy and reproducibility. So the acceptable titers are between 1:4 to 1:32. Now, a lot of people even think 1:64 may be okay, but we generally in our department try to reduce the titers to around less than 1:8 or 1:4. The value of post-transplant monitoring of the titers is uncertain. What about the recipient desensitization? So desensitization begins in several parts. That you have to remove the antibodies because these antibodies are present and they would harm the graft. We need to modulate the B cell immunity because if we do not modulate, the antibodies will come back with vengeance, and we need to have a maintenance immunosuppression. So what are the methods of removing the antibody? This is the classical plasmapheresis that is cheap, easy to do, and removes all the antibodies, but it is non-specific. It also removes the albumin, so albumin has to be given. It also removes the coagulation factors. So patients who undergo plasmapheresis, and if they have not been given plasma in the last plasmapheresis, they tend to bleed, and the surgeons will be unhappy. So normally, though we use this technique, we usually do the last plasma with AB group plasma, and therefore the bleeding is much less. There are other techniques where you do a double filtration, where you return the albumin back to the patient, and the advantage is that you don't have to supplement albumin, which is very expensive, and you only remove the antibodies. Okay. And the third technique is there where you remove the IgG antibodies using an adsorption column, but the IgM are not removed. But as I discussed, that IgM may not be critical in ABO incompatible transplants. Important to say that when you remove the IgG, it is non-specific when you use the immunoadsorption, and you also remove antibodies which are again to HLA classes, which will be some advantage to it. And the fourth and the most expensive technique and the most specific technique is to use columns which would specifically bind to NTA or NTB antibody, and therefore it removes only the putative antibodies and no other antibodies. This would be very specific. These columns are available from Sweden. They are expensive, and therefore we are not using it as a routine. But some cases where we need to do it where titers are very high, we have used it in some cases. As you can see here, there are several options in the ABO incompatible transplant. But important to tell you that you have to do some degree of adsorption or plasmapheresis, and whichever technique you use, some technique has to be used, and no difference is found in whichever technique you use. In the immunomodulation, as we said, that once you remove the antibody, the second step is to reduce the production of the antibody. And the important thing is, in the past, people are doing splenectomy, but splenectomy has now been replaced by rituximab. Rituximab is an anti-CD19 antibody, which anti-CD20 antibody, and which is as good as doing a medical splenectomy. The dose is very variable, but we use generally 375 milligram per meter square, but nowadays sometimes also use a lower dose, about 100 to 200 milligram. People have tried to do it without the use of rituximab, and there is data to show that one can get reasonably good results, but I think we go with the usual trend of using the rituximab, that is anti-CD20 antibodies. What about the use of IVIG? IVIG, when we do a plasmapheresis, we remove IVIG, and there is some thinking that we need to replace it. Generally, we only replace a small amount. The disadvantage is because of transient rise in the ABO titers, and the use of IVIG is non-uniform across centers, but we use low-dose IVIG after the plasmapheresis. What about the baseline immunosuppression? IL-2 receptor blocking antibodies have been used, and sometimes you can do without using any more further depleting agents. We have already used rituximab in these patients. ATG is not desirable because when you block B cell with rituximab and then you try to block the T cell with ATG, you get a significant degree of immunosuppression, and that would lead to increased risk of infection and malignancies. And therefore, though we use ATG in the initial period, nowadays we don't use ATG. We use either IL-2 receptor blocker or we don't use any induction in the baseline immunosuppression. Our standard immunosuppression consists of prednisolone, MMF, that is mycophenolate and tacrolimus, and generally one should avoid steroid-free in this situation. So there are several protocols in Japan, Sweden, Mayo Clinic, and in the Hopkins and Korea and many different, but the essential principles are the same, that you try to remove the antibody by some technique, use immunosuppression prior to the transplant. Most centers would use rituximab, but like John Hopkins doesn't use rituximab, and they would give a lot of IVIG, and some other centers would not give IVIG. So there are some variations in each center, but the principles remain essentially the same. You need to suppress the antibody, you need to remove the antibody, and then put in the graft. So these are some of the registry data which I have shown that you get a good 5-year survival and 10 years of graft survival, as well as the patient survival is good. Both from these are Japanese data, and this comes from the Swiss registry. Similarly, the registry in the multicentric trials, this is again from the European and Australian data, which shows a good 3-year survival, similar to ABO compatible transplant. This comes from Sweden. This again comes from Switzerland, and this comes from US, showing 5 and 10 year survival, both ABO incompatible and compatible, nearly being similar to one another. Again, single center studies, these are from Japan, these are from US, and again from Sweden and Germany, all showing equitable outcomes in graft survival and patient survival in the short term and in the long term. So what is our experience about it? So this is the paper which will appear in the next issue of the Indigen of Nephrology. This is the preprint, and Dr. Aniket did a lot of hard work getting this paper together from our department. So our protocol essentially is to use rituximab about 15 days to 3 weeks prior to transplantation. We use a dose of 370 milligram per meter square. Now sometimes we will use a lower dose of 200 milligram. Always use rituximab about at least 2 weeks to 3 weeks prior to the transplantation. And the plasmapheresis should be started after at least 48 to 72 hours after rituximab. Otherwise, you'll plasmapherese the rituximab. We use plasmapheresis and give them a low dose IVIG after plasmapheresis. We start tacrolimus, MMF, at day -15. At the time of transplantation, we don't use nowadays much of the induction agent, but we sometimes use Simulate. In the past, we were using ATG, but nowadays we no longer use ATG. We try to bring the antibody down to 1:8, and the last plasmapheresis we do with AB blood group plasma FFP, because AB blood group FFP would not contain any antibodies, and therefore it would be a good way to do so that we don't give any antibodies, and it would provide all the coagulation factors, so the risk of bleeding post-transplant is minimized. So we compared 100 patients who have undergone ABO incompatible transplant from March 2013 till December 2019 with the chosen 100 controls were chosen on a propensity-based screening based on the age, the gender, the time of transplant, the donor characteristics, and the HLA mismatches to compare what is comparable between ABO incompatible and compatible transplant. So as you can see here, the ABO incompatible transplant we started in 2013 and has been gradually increasing, and it constitutes about 18 to 20% of our transplants till 2019. In 2020, the year of the pandemic, there has been a lot of disruptions, and the data I have not shown. The age, as you can see, the mean age is about 40 years, both in the ABO compatible and incompatible in the group that we compared. The donor age is around, again, 48. There are more males reflecting the social condition, cultural conditions of our country, 85% males to about 15% females. Donors, as you can see, which we are ashamed of, is there are more females than male donors, about 80% females. Again, a large proportion of them are spousal donors. mothers who are usually likely to come and sisters compared to what you would see in the male group. Again, about equal number of preemptive transplants. The vintage on dialysis was about 6 months in these patients. Most of them hypertensive, about 25% were diabetic. Second transplants were 12. This is a sizable number because once there is a family donor which is ABO compatible and the second transplant is required, then it is difficult to have a blood compatible donor. You end up doing an ABO incompatible transplant. And of the females, 14 out of 15 in this group had pregnancies and 13 out of 16 in this group had pregnancies, telling us that they are also sensitized. So this is a difficult group which we have previous transplants and previous pregnancies which are difficult because immunologically they are very active. Most of our patients in our country are both the CMV donor positive and recipient positive. About 50% who had more than 3 HLMS matches. These were mostly spousal donors, and less than 3 HLMS matches is usually the parents or the sibling donors. As you can understand and very well appreciate that most of the O group recipients have a difficult time getting a kidney, and therefore these form the large chunk of the patients who go for ABO incompatible transplants. So B2O group were 30 transplants, A1 to O were about 16 transplants. So this constituted about 50% of our transplants, and the remaining were A1 to AB and B to AB. This group A to B, actually this group should not exist because if we did a swap, we would not require to do A to B or B to A, and this would be very easy to swap. But many patients are not prepared to stay for the swap. They don't want to really share their donors with other donors, and therefore we ended up doing a couple of these type of A to B and B to A transplants. As you can see, the antibody titers before the transplant, they're usually the mean antibodies about 164 to 128, and about 5 plasmapheresis are required to remove these antibodies. So usually we start the plasmapheresis about 10 days prior to the transplant and then take it through the transplant. This gives us an idea how many plasmapheresis will be required depending upon the antibody titer to reach a target about 1:4 or 1:8. What about the desensitization? Most of the times we use rituximab in all the patients. We use rituximab plasmapheresis and IVIG in majority of the patients. As I said, very limited experience with double filtration, and only 2 patients we use glycosorb. Glycosorb is actually a column which specifically binds to anti-A or anti-B antibody. It is expensive, costs about 3,000 euros. So infrequently we have used it. What about the induction immunosuppression at the time of transplant? As you can see here, that in ABO compatible transplants, we have been using ATG or IL-2 receptor blocker. And as time goes by, a lot of ATG increases, especially the spousal transplants, we have used more. In ABO incompatible transplant, we use ATG in the beginning, but later part, we have stopped using ATG because we felt that when you combine, as I said earlier, rituximab and ATG, it becomes quite significantly immunosuppressed, and you tend to get more infections, and that's what we learned, and we have stopped doing that. And now, a sizable number of transplants we do without even using IL-2. And when you don't use the IL-2, the cost of a transplant is significantly low. The IL-2 costs about 1.2 lakhs. So the cost of a ABO incompatible transplant when you don't use induction and the cost of rituximab going down, the cost of ABO incompatible transplant now nearly becomes, or at least slightly expensive, but to the ABO compatible transplant and not really very expensive. What about the rejection? This is what we fear the most, and we have had our share of rejection. So the antibody-mediated rejection has seen about 15 patients and less in the compatible transplant. But this may be because we didn't really study all of them very aggressively because in the initial part, we did not have the donor-specific antibodies available. But at least the biopsy showed either ABMR or they showed some form of a TMA, and which we think may be specific. Either they are antibodies or they are sometimes in ABO incompatible transplant has been described in many other centers that you get a form of a TMA, which is seen much early in the course. But later on, as you see, the acute cellular rejections are no different. In fact, they are lower than that you get in ABO compatible transplants. And the timeline, you can see that after 6 months, you don't really see much of rejection. All the problems that happen in the first month after transplant. Again, about infections, they have been nearly similar both in ABO incompatible and compatible transplant. Urinary tract infections are the major thing happening early. But fortunately, now our rate of urinary tract infection has significantly gone down. We had a smattering of PCP, tuberculosis, herpes zoster, CMV, BK, and fungal infections, not really different from what you would get in the compatible or an incompatible transplant. What about the other complications? We have had malignancies, one in each, ureteric leak and some anastomotic leak in one, graft thrombosis, lymphocyl, and transplant renal artery was not really very different from compatible or incompatible and hematoma over here. What about the graft outcome function? If you can see, the follow-up has been about a median of about 23 months and 2 years in both the sites. Though they were slightly higher on the ABO or compatible, but I think that a lot of ABO incompatible who were not to do well actually dropped off in the early year. And therefore, you see all the ones who do well after a month or two, their creatinines remain really solid for a long period of time. And there is some thinking which I feel based on this data that when you use rituximab, probably there is some feeling that it might reduce, though we have not measured it, might reduce the donor-specific antibodies. So the chronic ABMR may be a little lower in this group compared to those of the compatible group. The graft losses we have had significant in the ABO incompatible compared to compatible. And that's, of course, there were initial period which I'll just share with you how it happened. The cause of graft loss, as I said, initial rejections in the ABO incompatible, but later on, they are not really different. Again, deaths were because of sepsis, because when you get a rejection, you try to treat them more aggressively, and they do get sepsis, and sometimes an unknown, they have a sudden death. So these are the deaths in the ABO incompatible and similar deaths in the ABO compatible transplant. If you see the outcome, the graft survival is slightly lower in the ABO incompatible compared to the compatible. The patient survival, again, as I said, there were some deaths. But when we try to analyze what happened in our first 50 ABO incompatible transplant and the next 50 ABO incompatible transplant, I think the first 50, as we all understand, whenever you start a new program of a new thing, there's a lot of learning to happen. And I think here is where we have learned. And now when we can analyze our last 50, we are coming closer to the ABO compatible transplants. And I think now we have become much smarter, know which patients to choose, what immunosuppression to use, how much antibody to reduce, and how to monitor in the early transplant period. And now we also have got donor-specific antibodies available with us. So we use that also to know whether anti-HLA antibodies are there or not. And I think that is where this, I think, is gratifying to see that this is now grafts are coming closer to each other. And of course, the initial first 50 transplant, they are little further apart. So in conclusion, outcome of ABO incompatible transplants is improving as we gain more experience. ABO incompatible kidney transplant is a good option for patients without blood group compatible donor, albeit with a slightly inferior outcome. But as I showed, as you gain more experience, it improves. Thank you very much. And back to Dr. Rajaput. If there are any questions, I will have to answer.